Thank you. I just want to say that that was a very inspiring presentation and creates a very important context for what we can talk about. What I'd like to do today is just introduce ourselves first by way of background and experience, and then launch into a conversation about nicotine. So my name is Ed Anselm, and I'm a clinical assistant professor of medicine at Mount Sinai in New York. I have over 40 years experience in tobacco cessation, and I now work almost exclusively in systems change for tobacco cessation. My prior career also includes years working in the managed care environment.
Hello, my name is Dr. Arcella Burton. I am Vice President of HealthX, one of the largest health information exchanges, and I am in New York State. And I'm here today to discuss one of my greatest fears, because nicotine is one of the leading addiction crises that no one talks about. And today we're going to have a conversation, and I hope it enlightens each and every one of you how dangerous this drug is. And I'm saying, yes, it's a drug. And I have some questions that I'm going to start this conversation out with. And I want to let you guys know, if you go online, you can see his article that was dated January 22nd, 2025 on nicotine. And I'm going to give you the correct title of the article because it's very, very informative. It's called Reimbursement for Tobacco Cessation, New Models for Fee-for-Service, ACO, and Capitation. I'm going to talk, because I come from the world of managed care and capitation and value-based payment, I have to say this, had the #1 value-based contract in the state of New York with Mount Sinai that was $8 million in savings after the second year. So I want to talk to you about your article. One of the things that you raised is that 1/3 of the people that seek smoking, they want to quit smoking, 1/3 of them tend not to do it, or they don't believe in evidence-based therapies. Why do you think that is?
Well, let me just restate the statistics. About 55% of people who use cigarettes want to stop. When they try to stop, they don't use evidence-based treatments. And this is my deepest concern, that patients, people who use tobacco, are not getting good advice. We know that they're not getting the advice from their doctors. How do we know that? We know that when they try to quit smoking, they don't use the medications that are available at no charge if you have health insurance. They don't use the counseling, which is available by telephone at no charge, whether you have health insurance or not. Mm-hmm. And they don't use the counseling that's provided by their health plan. They're not using the services. So even when they get advice to quit, even when they're motivated to quit, they don't make an effective quit attempt. And that's just the beginning of the story, because what I study is why doctors don't give good advice. Mm-hmm. But it's a larger universe. We don't talk about tobacco at all. The only place where we're good about tobacco is in addressing the issue of kids using vapes. Mm-hmm. This is a tremendous public health success. All right, for the last 10 years, there's been major effort to help young people avoid vaping. And we had a big scare a couple of years back with a lot of, literally an epidemic of vaping by kids, mm-hmm. and some harmful effects when they were playing with the vapes themselves, mm-hmm. causing serious lung injury, yes. All right? But today, the prevalence of tobacco use among people, among teenagers, is extremely low. It's the lowest it's ever been. And vaping is actually less and less common. So the public health strategy directed at young people has been very effective. However, when you're talking about adults, the older you get, the less likely you are to get advice to change your behavior, all right? And by the way, when I talk about behavior change, I'm not just talking about using effective using effective strategies to change your tobacco use pattern. I'm interested in helping people lower their risk of disease. It amazes me that we're not talking, just as the last conversation before us gave us a chance to understand how we have a broken system for treatment of substance abuse. Well, we have a broken system for the treatment of tobacco abuse.
And I want to address this, the broken system for tobacco use. I think some of the problem here is that most people don't consider it a drug. How do we get this out to the public that it's really a drug and it needs to be, because like you said, we do it for the children, and I know it's changed, especially in New York, but I know in New York we still see these big ads of people, young adults, 36, 40, having a heart attack. You've probably seen the commercials yourselves where it's like, I'm 42 and I had a heart attack at 36 from smoking. How do we get this so that everyone knows about this and that you see the commercials, but it's not stopping anything?
Well,
so what's going on?
So I think that the barn door is open on using things. I had if anyone sat at my table, so I had 6 cups of coffee. And so that's how I manage my mood. And lots of people use things, substances, chocolate, alcohol, pills. People use a variety of techniques to, manage their mood. So I don't believe that calling it a drug is going to be an effective strategy when that barn door has been open for decades, I suggest that we take it in a different direction. That is, if you're using nicotine, you should know your choices. And if you're treating someone with nicotine, you should help inform your patients about their choices. And their choices involve quitting, and there are many techniques for quitting that are underutilized, and there are methods for harm reduction. We have opened new territories in understanding for the treatment of people who have substance abuse, and one of them is harm reduction. We have needle exchange programs, methadone, heroin. These aren't fully effective treatments, but they're harm-reducing treatments, all right? So I think we need to have a conversation about harm reduction for the many tobacco users who continue to smoke. We know that people who smoke cigarettes are going to live 10 years less on average. That's pretty remarkable, really, if you know the future. Why not help that individual lower their risk? They could go to vape, or they could go to Zyn, they can go to snus, and we could talk about any of these different products, but you can go to the FDA website where they have detailed a continuum of nicotine-containing products that allows individuals to choose the level of risk. And let me emphasize the point you made. Nicotine is a drug. There is no safe, the nicotine products that are not FDA approved are not safe, all right? So there are harms for using nicotine. But my message is that we should engage our patients and our communities in understanding the continuum of risk and helping them move down that continuum. And here's a surprise. When people move down that continuum of risk, what they learn is something called self-efficacy. Self-efficacy is the concept that you can do something about your situation, all right? I'm capable of losing weight. I'm capable of exercising more. Now it's just a question of doing it and sustaining it. But still, I have a sense of self-efficacy regarding these personal changes. So the interesting thing is to teach people that they are not addicted, that they can change. When you label someone as an addict, as we heard in the last talk, what does it do? It disempowers them. It shuts down communication. Why not tell people that they have choices? Oh, will you use nicotine? Well, why are you smoking? All the younger people have moved to vaping. All right, so why not vape? You know what happens when they vape? They found out that they can change their behavior. They develop a sense of self-efficacy. It's really interesting. What we do now at Mount Sinai is they try to give every patient varenicline, which used to be called Chantix, but it's now available in generic form. And they say, why don't you engage in a trial of quitting? See, a lot of people don't think that they can change their behavior. So why not give them a trial? There's no harm, there's no judgment. I just want you to try. See if you like it. What you may find out is that you can control your behavior. So why not give it a try? And it's a surprising thing in healthcare. We used to use something called stages of change. How many people know about stages of change here, right? So stages of change, this is, as a psychology major, so I love to cite the authors. Prochaska and DiClemente wrote the trans-theoretical stage change model, which said that we don't want to know a psychodynamic explanation. We don't want to know a behavioral explanation. When we want to find out what's in the person's mind, we ask them if they're ready to change. All right? Everyone's done this. I've taught thousands of doctors about stages of change, and I want that lecture back because I was wrong, okay? The theory is wrong. Because it turns out that I could show you great evidence that even when people say, doctor, I don't believe I'll be able to quit in the next 6 months, all right? If you can engage them in a trial of quitting, guess what happens? A large proportion of them are able to quit. That's surprising. So we have exciting news to tell people if we could only develop the vehicle to communicate that news.
I have a question for you. So you gave us a lot of information. You're very compassionate. How do we get our doctors, our other doctors, to be compassionate? Most people will go and see a primary care doctor once a year. If they're healthy or they think they're healthy, they only go once a year. So if I had a doctor like you and I know that I could have this choice, how do we motivate other doctors to speak to people about this?
Well, here's another surprise. Doctors aren't as good as we wish. And the reason is they aren't, right? I mean, yeah, because they don't have enough time. I mean, they have to see 4 patients an hour, 6 patients an hour in some setting. How can they possibly understand all of my psychosocial issues? And boy, do I have issues in 15 minutes. It's not possible. Right? What we need in order to help deliver the message that I just articulated is a change in the system. And that's really what my article is about. Yes. I'm interested in changing the way we provide care. All right? And when you organize a system of delivery, you can send clear, consistent, linguistically and culturally appropriate messages to your patients in an effective manner. And the way you do that is by engaging everybody in the practice. That is, it's not just the doctor in the room, but anyone who's in the medical practice can deliver an effective message to help someone quit smoking. The doctor says, I want you to talk to my office assistant, my nurse, or my secretary about quitting smoking, all right? We're going to refer you to the quit line because we refer everybody to the quit line. We think they're fantastic. By the way, when I think they're fantastic, they really are. But we think they're fantastic in helping people quit smoking, and we want them to call you, all right? Would you be willing to take that call? You see?
Wow.
So, but that message doesn't come from the doctor. It comes from the office assistant, who may or may not have a little bit more time with a little bit of training. There's all sorts of training programs available. It's in the CDC website. It's called Million Hearts. It's in the American Academy of Practice, Family Practice. It's called Champions. And so we can train the office staff to give the message. And here's the interesting thing for those of you who are running a medical practice. What my article shows is that when you do this consistently, you'll make more money. All right? And that could be a motivator. You know, that could be a change particle. You know, something that transforms and catalyzes the way we think about healthcare. Because everything in healthcare has been commodified. There's a price to everything. So historically and culturally, the add-on code for talking to a patient for more than 3 minutes about tobacco cessation. By the way, it's a message that can be given by anyone in a white coat, all right, in the doctor's office. That thing cost $15 under Medicare and around $8 or $9 on Medicaid, and someplace in between for the commercial plans, depending on what the fee schedule is. So you see, but doctors don't do it because it's so low. But we have treatments that are available for every patient, regardless of their readiness to change. I told you before that readiness to change is a trap. It's an intellectual cul-de-sac where you're going to get lost. Stop asking. Start working with your patient. Develop a system in your practice, and you know you can just go to my website and see how to do that. And develop a system whereby every clinician in your office now engages in a clear, consistent message, and you track and measure the outcomes. So you ask how you manage change. It's not just by, plugging in this module. It's about saying that we as a medical practice, we as a health system, are committed to changing the tobacco use continuum in our practices, all right? Very few practices measure their performance in tobacco cessation, neither the process nor the outcome. Google it, and see what literature is out there on measuring process in tobacco cessation on a practice or health plan level. What you'll find out is the article from Kaiser Permanente of North Carolina, and nobody else. University of Wisconsin has another paper. Okay, that's 2 articles. I'll give you the citations. But there's a gap there. If you don't measure it, how could you manage it? So if you really want to change, if you want to capture the revenue, if you want to help your patients, all right, if you want to install a new choice architecture, isn't that a fancy phrase? A new choice architecture for tobacco cessation and harm reduction in your practice, it has to start with leadership.
So I have a question for you. This is a segue to it. So leadership says, we know that we can bill for this, but the documentation, CMS puts too much information for documentation. I don't have time for that. What do you say to a practitioner or an office system that says they don't have enough time to put that in there? I know what I see from the data we collect. We hardly ever get any data in New York from systems unless it's a behavioral health organization that will do some smoking cessation or an FQHC, because as we know with FQHCs, the reimbursement is bundled under prospective payment system. And there's some organization that have some VBP, but how do you get them to change and to go into the system knowing that they have to put documentation, and people don't want to put all that documentation for such a little bit of money? What do you say to it?
Well, I don't know that it's a little bit of money. If you look at the article that I published, it was $6 million over 3 years for an 8-hospital system. So I think we could get the attention of any CEO with that kind of scale of dollars. We're talking about millions of dollars for a hospital system, and tens of thousands or hundreds of thousands of dollars, depending on the size of your practice. But it starts with how you manage change within your system. And the first thing is to understand that the electronic medical record has to capture that system. The majority of the clinicians I know use NextGen. You have to take their tobacco module and plug it in. There's some imperfections because the tobacco module doesn't quite capture all of the nuances of tobacco use because it doesn't differentiate between vaping and smoking. Right. Interestingly, on the billing side, vaping and smoking, they're still tobacco, they're still billable, and they're still actionable. You can help the health of that patient by helping them quit vaping too. So why not do that? But then first is the EMR. Then there's the tobacco use identification process. And there is a literature about this. The idea is when someone comes to a practice, someone has to ask them if they smoke. I used to laugh because my primary care physician at NYU would ask me every time I went if I smoke. And why did he do that? Not to needle me because this is my whole career, but rather because he asks every patient every time. It's the system. By the way, Kaiser Permanente, they don't have the doctor ask the tobacco use status. They have the office assistant or the medical assistant ask. And they have an algorithm so that they don't waste their time asking all the previous people who never smoked every single time they come in, because it's very uncommon that an adult will start smoking, right? So why ask them, right? Why waste time doing it, you see? So there's an algorithm that there's a process for applying a change model. EMR, tobacco use identification, managing the flow in the office. I mean, you have to know how your patients are going to flow through the office and who's going to do this. And you want to make sure that the clinicians understand what it is that you're trying to change. And then you need to measure them. Right? This is really amazing. So much of healthcare, we had this great session yesterday about diabetes. And everyone is talking about how we measure and manage A1C. Isn't it fabulous? And the reason is for the last 15 years, the National Commission for Quality Assurance has been asking every doctor to report to every health plan about how they're doing on managing A1C, right? We're not doing that for tobacco. All right, I sat on the National Quality Forum. They have a metric that could be used, but they're not doing it. So what happens when you don't measure it? You can't manage it. Okay, so we've allowed this. We've acquiesced. Broken system, anyone? Right? So,
Broken system.
Broken system. So you ask. So if the leadership decides, they need to delegate to a number of champions within the system. The cookbook is there. It's the CDC cookbook. There's a few other cookbooks available. You can decide which one fits your institution and your change process. And you need to measure it. That's how you do it.
So this is very interesting, and I like the way that you're thinking and you're putting the system. So when we think about a system, and we're thinking about the person that's in the system, and let's just say they go to your system, but they also have some outside doctors, and the outside doctor says to them, don't worry about it. You've cut down on your smoking. You don't need that. So you don't need to go back there anymore. How do you get that person to re-engage?
Well, so people nowadays do seek medical care at multiple locations, and that's true. I think you can engage people best by helping them see the change. So if people understood that within several days, they can see good physiologic effects of their tobacco cessation, within several weeks or months, they can be through the challenges, most of the challenges with relapse if they understand and can see the change. But I have no answer to mixed messages from other people. I don't know the answer to that. I don't want to lose the opportunity to identify the continuum of choices that people have, because the clinicians need to empower individuals to make choices. And this is a key message. It's not just that we focus on the leadership level, but I really think that the message needs to be trickled down to the individual communication. All right? And I think that that's a key issue from my perspective. Because if we don't give people choices, we're going to fail. We're going to fail.
And I think that's where it comes to what I've seen, and I see it a lot, especially when someone's really trying to quit and they're trying to have, they get a choice from you, but then they go somewhere else and their choice is, well, this is my choice. So you get the mixed message and you say, I don't need it. I'm just not going to quit. You know, I see my mother smoked for 40 years and she's still alive. You know, even though I have my choice is to stay. No, I'm not going to quit.
So my typical answer for that is to reframe the question. So people are choosing their immediate gratification because they really like smoking. They like what smoking does for them. It helps them manage their mood. One of the moods that's being managed is their incipient withdrawal, because if you smoke at a certain level and you stop smoking, well, you're going to feel bad, right? The medications are really helpful. But what I try to do is reframe the question. We're from New York State, where it costs $10.75, to buy a pack of cigarettes, all right? I help them do the math, okay? I say, well, how much do you spend in a week, in a month, in a year? What would you do with that money? And I write it down in a chart. And when they come back next time, because, they really were kind of ambivalent about it, and they come back next time, have you thought about that trip to Las Vegas? Luxor, you could be at the Luxor a year from now, I usually use Orlando because that's a much more favorite thing. You can bring the grandchildren. But when you do the math, you give people other choices, and the other choices includes being with their kids and their grandchildren, because a lot of households have gone tobacco-free. Why be an outcast outside in the hallway when, in fact, you can come into the house and be greeted, and not saying you smoke like tobacco, you smell like tobacco, Granny. You've been smoking again? No one wants that message. Well, that's preventable. So my message to individuals who, people who don't really want to have that conversation is to reframe it for them in the way that matters. The immediate gratifications, you have to ask and acknowledge. Some people like smoking, all right? Some people really like smoking, and they enjoy the hit of nicotine and that harshness in the back of their throat, okay? Let's acknowledge that as being true. But why do you have to get that from a cigarette? Have you tried vaping? Have you tried IQOS? There's a new product out there. It's a plastic tube. It looks like a cigarette, but it doesn't burn anything. The thing that'll kill you from tobacco is the tar. All right? So why not get the nicotine you need, the flavor, and that hit in the back of your throat, which you seem to like, from a product that's not going to kill you, right? So I think there are options, and people should be informed about options. You know who's great at exploring the options? The Quit line. It's 1-800-QUIT-NOW is the number for the United States, and they'll tie you into the state quit line. And I have to say, I have run teaching programs for those counselors. They are better than I am. Okay, I'd rather have you talk to them than talk to me, because they do it all day, all the time, and they really know what they're doing. And they understand how to take someone on a journey through vaping. 1 out of 3 people who calls the Quit line is trying to either quit smoking with vaping or quit vaping. Right? So they really have a lot of experience in talking to people in the details, the day-to-day operational details of changing their behavior. So more about choices. In quitting smoking, for people who have difficulty in quitting smoking, the number one factor is counseling. And people are just giving a medication. There are 3 to 1 ratio where doctors give medications and don't give counseling, and the patient never goes for counseling. Counseling, to one of my Quit line colleagues, doubles the effectiveness of any intervention that you do. So the medications really prevent withdrawal symptoms, but there are times, weeks and months later, where the behavioral strategies that they can teach you on the phone are really, really helpful. And if you relapse, and relapse is common, people who are successful in quitting smoking can make up to 20 quit attempts before they're successful. That's a lot of effort, and I give them credit. But I bet you they would have fewer quit attempts if they use medication and counseling. But you can also use 2 medications together. And remember, if you have insurance, these medications are free. There's no cost share whatsoever to get 2 medications to help you quit smoking, and the counseling is, of course, free. So why are people not doing it? Because we're not telling them to do it, all right?
And I have a question. So if I have commercial insurance, we know, and so does Medicare does this too. Counseling for smoking cessation, they have a limit. So what if you reach your limit? Because we know, we're from New York, Medicaid gives 20 visits a year for counseling. Medicare does 8. So what happens? Can I go to quit line even though my insurance is not going to pay for it?
Okay, so the quit lines don't get paid by insurance. The
Right.
quit lines are paid for based by several mechanisms on a state-by-state level, okay? So it's true that there are 8 sessions. Very few people go for 8 sessions, okay? The 8-session limit is for medical office-based tobacco cessation services. When I was at Aetna and I did study the entire health plan data on tobacco cessation counseling, the average number of counseling sessions per tobacco user was 1.1. So the doctor never gave more than 1 session, all right? And very, very rarely they gave a second session, all right? And I found the same thing at Mount Sinai. We could go over that data. Vanderbilt, what was the other? UCLA, and I bet you any other health system that I test, doctors are not counseling, they're not billing for counseling, and we already know that the many, many instances in which they're prescribing medications but they're not billing. So those visits are certainly reimbursable, all right? So
A lot of miss opportunities,
yeah, so
I find.
I would not say that the CMS limit, which is adopted by most commercial health plans, adopt the CMS rules, never has been a threshold, and never has been a problem. It could be that some people get cessation advice in multiple clinical locations, and that some of those claims might be denied when everyone does what we're talking about here.
Right.
But I don't think that's going to happen.
Well, I just see, when I see the data and I see where it's missed, where they're not putting it in, and you're like, okay, well, how did they get this medication if you didn't counsel them?
Exactly
so I
my
find,
point.
And I do find that, and from speaking to some BHOs, behavioral health organizations, they say, well, we don't put it in for billing because we don't get paid for it. And I said, why not? Have you even tried? Do you know if you meet the threshold? And if you don't meet the threshold, put it in for billing and get paid for it.
Well, so I think there's a cognitive barrier against treatment of certain conditions. We learned that in the last session, all right? We never, by the way, we never went upstream, and I'm sorry there wasn't any time to comment on it, but I think it's appropriate to understand that there's a role for prevention, not just in educating people, but understanding that if you're talking about the major public health challenges that we have, that is, we're talking about profound substance abuse, tobacco, obesity, they have a common thread, right? And that's adverse child events. And if you understand what happens in people's childhoods, then you realize that divorce, frequent relocation, homelessness for a kid, a parent in prison, these are adverse childhood events that have a profound impact on someone's future health. All right, so if you really want to prevent the social, medical problems that we've discussed, we need to address the underlying issue behind adverse childhood events, which is poverty. All right, if you want to do one thing to improve public health, then look at poverty, understand it, think minimum wage, think housing, all right? You really want to solve these problems, but we can't solve that in this session. What we're talking about today is something that's extremely actionable with you as a clinician in your office tomorrow, with your billing system over the next couple of weeks. You can make a difference for your patients, You can make a difference for yourselves, all right, in your own sense of organizational self-efficacy. And that's a real message for everyone here today. And that's the message, the empowering message of this entire conference, is that you take the information you get here, you put it into practice, you watch it make a difference for your patients, for your revenue stream, and then you do better. You use that knowledge and feedback to continuously improve.
I see we're running out of time. Does anyone have any questions? Yes.
Hi.
Hey,
so
Reg.
this is a kind of a far-fetched question, but it just popped in my head while you were talking about the nicotine and how as far as needing counseling through the quitting aspect of it. And I was wondering, could quitting cigarettes be a form of postpartum disorder? Because, you know, we say postpartum with babies, you know, stuff like that, but something physical, but what if it's also something mental, where when my mom used to quit or smoke and everything, she used to say that she's used to always just doing something with her hands. And so she had to find something to do with her hands, but when she couldn't, she'd go right back to the whole hand, you know, just the motion of it. So could it be more of a postpartum mental thing as well? And could there be counseling in that form to help them break that?
Well, this is the problem when we have, thank you, that's a great question, because when we think about tobacco use, what we don't realize is that there's a physical and cultural dimension to tobacco use. A lot of tobacco use is social. A lot of tobacco use is ritualistic. Look, some people curl their hair when they think deeply, okay? Or pull their beards. These ritualistic behaviors help in concentration. Other people chew gum or suck on a straw or use their tobacco as a form of ritualistic behavior. But you touched on another important issue. We never talked about the demographics of tobacco use, right? Increasingly, it correlates with socioeconomic status, mental health, all right? Rural areas. So it turns out that tobacco users not infrequently have mental illnesses, and that nicotine is a form of self-medication. If you think about it, nicotine is an antidepressant. If you have some low-level depression, would you really want to stop your antidepressant? Wouldn't it be difficult? Think about it. That's another way I've been able to help people get into behavioral health treatment over the years. You have such difficulty quitting smoking? You know, nicotine is an antidepressant. I know you have these issues. Why don't you talk to someone about it? So it's an interesting hook, and I'm sorry I didn't mention it earlier.
Thank you all. It was a pleasure speaking.
Thank you. Thank you all.